Okay, we are back to our series. We have a few studies on the docket tonight, and I've got a few opinions on them. Some that I don't disagree with, but I think we need to parse out what's actually going on. So let's go through them. First one, the effect of mild to moderate knee osteoarthritis on the gait. Basically, what happens when you start developing osteoarthritis? Well, they basically claim that knee osteoarthritis induces changes in biomechanical alterations to gait, which become more pronounced with advancing disease severity. So they think that it highlights the importance for early detection and tailored rehab strategies to improve mobility and prevent further joint degeneration. You kind of had me up to that last point because and this is where blanket terms, you got to give some people the benefit of the doubt. And I see this on social media all the time. Blanket terms like that are devoid of the required nuance and complexities of life because there is no guarantee that with improved biomechanics based on their parameters that you would actually reduce or slow down the degeneration associated with knee osteoarthritis, because there's a lot of brands of osteoarthritis. There's some that are inflammatory and autoimmune, and alterations of biomechanics are not going to change or slow down that process. So really it comes down to also understanding that you are not going to out biomechanic or improve the biomechanics to such a degree that you will stop degeneration, because time and age are a thing. We cannot get around that. Now, there's rates of degeneration, and that is certainly something that we can talk about. And that has been replete with other studies that show rates of degeneration, whether it is joint, whether it is muscular mass and tissue quality, the actual rates of deterioration can be highly, highly affected by your lifestyle choices. You know, do you choose to stay physically active? Do you stay relatively healthy from a sleep standpoint, a dietary standpoint, etc.? So you can certainly affect how fast things take place in your body, but to blanket say, you know, prevent further joint degeneration, it's like, compared to what? If it's their age adjusted norm and if it's exact same style of osteoarthritis, okay, we may have a discussion. But osteoarthritis in general, you know, we have inflammatory arthritis, your stock standard osteoarthritis, there's psoriatic arthritis, there is, oh, I'm blanking now. It's late on a day. You cut me some slack. Rheumatoid arthritis. There's a lot of things that are just arthritis. So I'm not against improving biomechanics so long as the goal isn't an arbitrary x-ray to show some sort of degeneration. You know, if it's like a bone mineral quality thing with a DEXA scan, then we're getting into osteopenia and I just gave a talk on this too. Anyway, bone mineral loss, osteoporosis, there it is. Wow. You know what? I'm leaving this in here. I'm human. So it really comes down to functional qualities, functional aspirations. So maybe changing the biokinematics of these people with knee osteoarthritis improves functional capacity, functional ability, and how these people interact in their day-to-day life. And that is something that I think is a much better pursuit than just the arbitrary joint degeneration. Next up, because again, I can get on a soapbox with any one of these. Spinal and hip mobility with disability among patients with chronic low back pain. So this one, they had a lot of participants, relatively evenly distributed between male and female. And first, here's the thing to note: disability was significantly associated with spinal and hip mobility impairments in the chronic low back pain group, but not those with intermediate, so low back pain or no back pain at all. In the parameters that they measured, these certain motions, so lumbar, sagittal, coronal mobility, basically different angles that they measured it at, were associated with higher disability scores. I like this sentence, and this is why I include this study. In contrast, most mobility parameters showed no significant association with pain on their own. So this is where People will develop their own motor patterns, their own ways to go about given tasks, and they are an independent factor to consider. They are not per se, how do I phrase this? While you will find in this conclusion section that with the chronic low back pain, it's like two birds of a feather. When you have this chronic low back pain factor, it's essentially a feed back and forth mechanism. Chronic low back pain may have you avoid certain movements. Those certain movements will really start to hamper how you go about and live your life, which will have other effects, social effects, emotional effects, lifestyle effects, sleep effects, lots of things going on. And now it's kind of this domino feed forward effect where, chicken and the egg was a mobility issue, and then you develop pain, maybe not as likely. You develop pain, then you kind of work around the problem. Okay, that's more likely. But now you have these mobility impairments, which is now potentially exacerbating or maintaining the chronic back pain. And it's just a mess. But I like the fact that they note that, because in the intermediate or no low back pain, you may have had a mobility issue. And I've seen that with a lot of patients. Like I will, go through my clinical audit process with them, and there will be something that's like, oh, you have like no motion there, but you have to clinically correlate it. Did it really matter for them? Well, no, it doesn't matter how I treat this individual, because they can work through whatever it is just fine. And I don't need to try and give them more motion when they may or may not be able to attain it. And they're moving in the world just fine. As evidence here by mobility parameters show no significant association with pain. If it ain't broke, don't fix it. But it is something to consider if we're talking about the chronic low back pain case. And this is where the conclusion comes in. So I'll tie you back to here. It demonstrates that both spinal and hip mobility impairments are independently associated with disability in individuals with chronic low back pain, and they were equal, hip and spinal mobility. So if you have a chronic low back pain case, it may be your low back motion is actually just fine. But what may be feeding into the disability is you have like no hip motion, because that's just the workaround that your body had at the time when you developed this low back pain. And vice versa. Maybe your low back pain flavor, let's say, it's actually tightening up your low back. So we really can't be super myopic when we are treating low back pain, especially chronic low back pain cases. We have to take a look at the individual in front of us, see what their body chose to use as workarounds, and apply different clinical interventions accordingly to get them back doing what they need to do. So this study, it was fun. It kind of tickled me a little bit, but we're going to move on to this one. Benefits and harms of exercise therapy and physical activity for low back pain. This one is a big review. It's an umbrella review with 70 systematic reviews, 43 meta-analyses, 7 network meta-analyses. And I'll just kind of read through it at first. So first, 6 out of 10 of the reviews for secondary prevention of low back pain had a small benefit for general exercise and leisure time physical activity. For low back pain management, most of the reviews reported that exercise therapies such as Pilates, motor control, etc., showed small beneficial effects on pain and disability compared to minimal intervention in the short term. 7 meta-analyses, network of meta-analyses, favored motor control and Pilates over other forms of exercise to reduce pain, but low certainty. Adverse events were reported in less than 31% of the reviews, usually involving post-exercise soreness. So that's the thing, if you actually read some of these studies on their own, if you just take a look at adverse events, human nature usually has us looking at, oh my gosh, an adverse event. What was that? Did somebody break a bone, tear a muscle, die? No, you really have to take a look at what are the parameters that include adverse events. And in this one, it was post-exercise soreness. So you did something and your muscles got a little sore. That was an adverse event, and it was reported in less than 31% of the actual reviews of these studies. And adverse events were minor, and no serious adverse events were reported. So again, they categorize them. Blanket statement, minor, serious, maybe you see something like catastrophic, severe, significant. Always worth digging into if you're doing this sort of reading. So their conclusion was there's low to moderate certainty that exercise therapy and leisure time physical activity are beneficial for improving pain and preventing recurrence of low back pain. There's a plus. They like to include this, however. Evidence on the potential harms of these interventions is limited, and adverse events related to exercise and physical activity remain under investigated. Honestly, I don't care. We're living beings. We're trying to go about our lives, play our sports. There's no such thing as a zero risk activity. And no matter like anything I do in the office, there's no such thing as a zero risk activity. Even the most benign things technically aren't zero risk. I walk outside, I'm exposed to the elements. I walk across the street, I'm running the risk of, getting bumped by a car. I walk under a tree, I run the risk of getting hit by an acorn, a squirrel, or a branch. There is no such thing as zero risk. So that whole fact about, well, adverse events related to exercise and physical activity remain under investigated, from a population standpoint, I don't care as much. Now, if we're talking about given conditions, if we're talking about level of physical activity towards adverse events, yeah, there's different studies out there that show like different activities had different risk factors associated with it. I'm not talking about that. I'm talking about, I don't care so much that there are 30%, 31% of these reviews have post-exercise. I don't care. Like, even if it's a, low to moderate certainty that there's a small benefit to preventing low back pain, take it. The adverse events are minor, and the potential benefits of physical activity and exercise, I mean, I'll say it this way because this is what was on social media recently. Again, if you could capture the benefits of exercise as a whole and put it in a pill, it would be the best pill on earth. Like, everybody be taking it all the time. It'd beat out vitamins. It would beat out everything. The benefits of exercise therapy, if you put it in pill form and people could just take it, would be one of the best medicines ever made, bar none. So the benefits are in low back pain specifically, maybe clinically small to moderate. There's low to moderate certainty. Don't need to be that much higher for this. And potential harms for these interventions is limited. Just don't care. You go out, you do you. If you need any help or guidance, we're here. But we've got 3 more studies. I'm running the risk of getting preachy, and this might get to be a really long video if I don't hustle. Preventing chronic low back pain, investigating the role of Pilates in subacute management. So basically you have 3 general stages when it comes to healing and healing physiology. You have the acute stage, which there's some minor disagreements. It ranges from incident, the actual incident. Some will say that actual day, so 24 hours. Some will say up to 72 hours. Basically, I'll blanket it up at within this 72-hour window, acute. Anything from, and this is where it overlaps, some will say after 24 hours, up to 2 weeks. Others will say after 72 hours, up to 3 weeks. I digress. So we have this subacute stage. So they just got some episode of low back pain. Now you're put into the study and you're given a home exercise program, and supervised Pilates. I'm going to emphasize that, supervised Pilates. And what they found was both groups had really great responses. Let's go right to the results here. Both groups exhibited significant improvements in all outcome measures, but they did note that Pilates showed superior reductions in pain intensity and functional disability. Quality of life scores improved more significantly in the Pilates group in physical function and general health. So you may think what they did, jump to the conclusion, Pilates-based rehab was more effective than a home-based exercise program in improving pain, disability, and quality of life in patients with subacute low back pain. I will disagree a little bit there, even though the study rate is just glaringly saying, well, no, it's not true. But hear me out. I think that the benefits associated with Pilates in this study came entirely down to the fact that it was monitored. Because we have a ton of other factors associated with pain and how somebody experiences it and goes through it. And what you have now is, the way that I'm reading this, is you just had a home exercise program where you gave people essentially a sheet of exercises to do on their own. I don't know how much education they have, and they are left up to their own devices to go through it, saying you're going to be fine, do the exercises, you'll get better. Well, and they did. And that is something worth noting. However, no matter how well trained you are, there's our human instinct and reaction to pain. No matter who you are, there is this natural flow that you're going to experience. There's always some level of uncertainty. There's always some subconscious avoidance or workaround or something. You have these blocks in place and they're a good thing most of the time. So if you give somebody just a blanket home exercise program, they're showing benefit, which is great. However, they may not go as hard as they would because they are trying to use pain as a gauge for them. They may be worried about their form. There's a lot of things that if you just left them to their own devices, yeah, they got better, great. But if these people also got guidance, I would really guess that they would have the same results as Pilates. Same. I think the Pilates group isn't the fact that Pilates as an approach necessarily is special. I think it's the fact that you had a supervised group, which means you had a person there to critique, maybe it was form or technique in regards to certain movements, which is reassuring oftentimes. And there's certain contextual factors where it's actually the opposite, but not making my point right now. You have somebody reassuring somebody about a technique like, oh, hey, Susan, you need to do this. Do you feel it here more? Well, yes. Well, now you're providing not just a tactile sensation for something for the patient to focus on. You have them thinking, okay, there's a Pilates expert telling me how to do this right. There's reinforcement going on. There's a lot of reassurance, and that alone is enough to have benefit in pain reduction. Basically, if we're thinking of pain not as purely mechanical and physical, but in this realm of what's called biopsychosocial, so there is a physical parameter, there's a mental parameter, and there is a social parameter. Pain is complex, and I could spend hours talking on it, acute, chronic, subcategories, etc. But long story short, everything in your life can and will affect it. Your mental state, sleep state, nutritional status, certain mechanical factors can play a big role. Social interactions in a group, everything can play a part in how your body basically dials up or down this pain cycle. And the fact that you had a supervised group going through a particular exercise protocol, you can't divorce the technique from the fact that they were supervised when comparing it to the home exercise, because you have somebody who can then, again, beating a dead horse here, you have somebody reassuring them, doing technique and like information, like modifying it on the fly, helping them, reassuring them, maybe telling them to, hey, if you don't feel that much pain, go harder, or if you feel that, go lighter, really helping them through the subacute phase. So I think the supervision part is what played a huge role in this. And this study is not conclusive in that Pilates was more beneficial. You have to find something where you take the supervised part out of the Pilates or add the supervised part into the home exercise program, then rerun the trial. Because I think we cannot blow by the fact that that simple line, oh, it's supervised. You can't underestimate how important and impactful that is for a lot of these people. Now, steroid injections in lumbar disc herniations, evidence synthesis from 72 randomized control trials of almost 8,000 patients. Basically, they compared epidural steroid injection with other manipulations in terms of pain control, quality of life, and other parameters compared to other available alternatives regarding that approach to pain. Analgesia is just pain. They compared it to non-guided versus guided, etc. Not really. Honestly, the point of the study, probably knowing those differences aren't that crucial. They basically said that epidural steroid injections had superior results to other conservative treatment modalities for sciatica. It's like, what? Really? Why are you talking about this? Well, because they said, yes, it does. It does surpass other methods, but it doesn't provide long-term results. So I'm not anti-injection at all. It's, again, as I've said in videos past, the right tool at the right time for the right person. Because if we look at the language here, they said, well, take a look. Surgery seems to have even a more immediate effect and better long-term outcome. I don't know about you, though. Knowing what I know about sciatica, I would really wait to understand what my options are and what brand of sciatica I have, what's really causing it, and if I gave everything else a fair shot first. Because surgical fixes for sciatica. I mean, it could be a disc herniation on a nerve that's causing it, which means you either need a discectomy, partial, total, that they might go in and do a fusion for. They might do certain nerve blocks, which for a sciatic nerve is pretty big, so they would probably be a little hesitant on, but I have heard of it. People might undergo SI fusions because there's mechanical load across the SI that the surgeon thinks is playing a part into the SI pain. And then successes for sciatica, it really comes down to a successful low back surgery when you have this radiating pain down the leg. They do not look at back pain with this. They entirely only look at the radiation. So, or the pain radiating down the leg. So if you have sciatica, pain going down the leg, and back pain, or maybe no back pain before the surgery, and you have major back pain after the surgery, but no leg pain anymore, that surgery is a success. That's exactly what it is. If the cessation of leg pain is achieved despite the quality of the low back symptoms, no symptoms or major pain, that doesn't matter in terms of a successful back surgery. So when we're taking a look at the language of the study, epidural steroid injections had superior results to conservative modalities for sciatica, but that was just in the short term. Long term, well, both short term and long term surgery has even more immediate results, the way you hope it would. It's surgery. Apart from different approaches, additional agents such as medication had additional effect when administered. Basically, we got to pick our poison. I personally am not anti-injection. It is quite literally down to what is your level of pain and what activity do you need to go back to and what's the time frame. Because again, if this sucks, but you can work through it, you're not in any danger, there's no red flags, and you're willing to work through it, we can give it a really fair shot and help improve this, so long as there's none of those red flags and we know it's not a surgical case. If it's one of those things where I've had patients before, it's like, I can't work with this pain at all. I can't even go through your treatment stock, let alone go back on the job, and I cannot take time away from work. Then we'll talk about getting the injection. Even though it doesn't have long-term benefits and results, it at least works in the short term, and we can get you back doing what you need to do and then rehab you through the rest of the process. Because again, for those patients as well, surgery also isn't an option unless it's in the extreme sense, because if you don't want to take time off of work, well, you're going to have time off of work with a surgery no matter what. So again, this is a tool in the toolbox. I think that many patients come in to me, get them too often too soon, but they shouldn't be disregarded entirely. There is a time and place, and we have to do a good job about finding that right time and place. Now, the last study. Relationship between the timing of physical therapy, commencement, and the duration of work disability. This is a retrospective analysis of work-related low back pain claims. So they just looked at work comp claims in Australia. And what they found, and I can see this and back this up personally. So they examined 9,000 accepted workers' comp claims. Patients who had not seen a physical therapist had the shorter duration of disability. Basically, they had a work comp claim that didn't require that much management or workup. So we'll just take those out of it. So of course they would have the shortest duration of disability. However, for those that did need a physical therapist, they found, and let me go in and highlight here. So when they adjusted the model, it demonstrated that compared to physical therapy, if you sought care within 7 days of injury, between 8 and 14 days, 15 and 30 days, and then greater than 30 days, it was associated with, drum roll, a 37%, let's see, where time ratios, 119%, and then a 315% increased likelihood of a longer disability duration, respectively. So we saw this with concussions. We're now seeing this with disability. If you need care, I'll just blanket it as some sort of conservative care, allopathic care, any care. If you genuinely need it, the longer you wait, the tougher it's going to be. Whether that's on the clinician, on the tools and resources they have available, whether that's on your body and how it's dealing with the injury at the time, with the resources it's got. or with it's just disability in general as a whole, as what this study showed. If you wait too long, it's tough. Do not suffer needlessly. And I like the conclusion. Workers with work-related low back pain undertaking PT, early commencement of PT was associated with a significantly shorter duration of disability. So like I've said in these other ones, man, if you need help, get help. And if that means you need us, we'll be waiting for you. So that was this review. Thanks for sticking with me this far, and I'll see you again in a week or two. Bye.